everyone. Good morning, good afternoon, and good evening, and welcome back to our annual Pain Center Conference, Advancing Pediatric Pain Care Equity, Addressing Challenges and Opportunities in Low and Middle Income Countries. For those I haven't had the pleasure of meeting, my name is Fiona Campbell. I'm co-director of the Pain Center at SickKids, and I'll be your moderator for this session entitled Chronic Pain in Children in India, sharing insights on the unique experiences of providing care in the hospital and in the community. So it is my distinct pleasure to introduce Dr. Gayatri Palat, Professor of Pain and Palliative Medicine at the MNJ Institute of Oncology and Regional Cancer Center in Hyderabad, where she was instrumental in founding the department. She has about 23 years of experience in pediatric palliative care, and in addition to being a founding member of the Pain Relief and Palliative Care Society, one of the largest palliative care programs in Telangana, Dr. Palat leads a unique pediatric palliative care program embedded within tertiary government hospitals and extends into the community through home-based care and hospice support for children. She also directs a highly successful fellowship program in Peds Palliative Care endorsed by the Royal College of Pediatrics and Child Health. Her efforts have also been instrumental in developing district-level palliative care programs across her region. Dr. Palat serves on the Board of Trustees of the International Children's Palliative Care Network. And with that, I will introduce Dr. Palat.
Good morning and good evening to those of you joining from the other side of the globe. Allow me to share my presentation. The topic of discussion today is about advancing pain care equity, addressing challenges and opportunities in low and middle income settings. Why are we giving so much importance to this? And we are doing an entire session around this issue is because chronic pain in children is often under-recognized and under-treated. If you look at the statistics, various studies have shown that 1/4 to 1/3 of children experience chronic pain. 1 in 20 experience moderate to high level of pain-related disability. Children with severe neurological impairment, which constitutes major chunk of children which we see in palliative care, almost daily they experience pain. In 41 to 42% of children with severe neurological impairment experience daily pain, which is often severe to profound degree in terms of severity. Children with serious medical conditions are exposed to frequent painful diagnostic and painful procedures. Example, bone marrow aspirations and lumbar puncture. A very interesting study which came in 2018 where they did look at the systematic review again. A systematic review showed that the neonates admitted to intensive care units frequently suffer through an average of 7 to 17 painful procedures per day. If you look at pediatric population in low and middle income country, 90% of world's young population live in low income and middle income countries. And children are disproportionately affected by potentially painful and life-limiting conditions. But how much the data? We really don't have good data, but very interesting systematic review which came in 2022 showed that general or multi-system involvement 20%, musculoskeletal pain 9%, abdominal pain 7%, headache 4%, and fibromyalgia 3% constituting the entire pain spectrum. Very interesting. Unlike which we read in textbook about chronic pain in children, which is mostly based on research in developed countries, what we see is some unique situations in a low and middle income country. One such situation is pain due to infectious diseases. When again, a review which came in 2018, various painful conditions due to systematic disease in various countries have been reported, like in Haiti, tungiasis leading to wound pain in 37% of children. Angola, HIV causing chronic pain in the ear 44%. Mali, cerebral malaria and headaches constituting 20%. Schistosomiasis causing abdominal pain 27%, headache 23%. Kenya, abdominal pain due to cryptosporidiosis 51%. So if you look at this spectrum, these are all very unusual circumstances, which is quite endemic to this region of the world. Similarly, malnutrition, which is so common in not so resource poor setting, often can lead to long-term systemic chronic inflammation and pain. Pain in children with cancer. Unfortunately, even though children with cancer and treatment is a success story in the West, children are still dying of pain in this region. And the pain can be because of progressive disease, but very much because of invasive procedures and treatment, because every aspect of cancer treatment is very invasive in children, into like for example bone marrow, diagnostic procedures before and after each chemotherapy, and then each chemotherapy is quite invasive in terms of intravenous, intrathecal, and often they may not have the privilege of having port to in order to prevent painful procedures, and of course the psychological distress which comes with ongoing cancer treatment in children and their families. I work in Hyderabad, and we run a huge pediatric palliative care, pain and palliative care program in two settings, in two hospital settings. One is MNG Institute of Oncology, which is a huge tertiary cancer hospital of 750 beds, and a neighboring children's hospital, Nilofer Children's Hospital, another tertiary referral hospital, and where we see children with a lot of non-cancer conditions. Just to give an examples of the painful conditions which we see in our setting. Childhood cancer, like I said, our children are still not, they come very late for treatment, and because of which, and many other reasons like dropout, the survival is still very poor. And and while they're undergoing cancer treatment, they experience a lot of pain due to various procedures, cancer pain, treatment related mucositis, cancer pain related bleed, disease progression, neuropathy, bone conditions, bone metastasis, abscesses. So many painful conditions which an average a child with cancer may experience during the entire cancer treatment, and if the disease progresses because of the progressive conditions and end of life care. So it's an extremely painful condition, and this is something very common to see in our setting. Other non-cancer painful conditions, often we don't think about what may happen to those children who are with non-cancer conditions. I'll give you some examples which we see typically in our hospital. A 55-year-old child brought with epidermolysis bullosa, multiple lesions on the skin, extremely excess cry, baby is dull and sick looking and reporting. We use scales to assess pain in small children and babies, like FLACA reporting 6 out of 10, which is quite a moderate degree pain. Collodion baby, 2 hours of life in NICU, and neonatal NIP score showed 6 out of 7. Toxic epidermolysis necrolysis. There was lesion all over the body post or intake of an antibiotic, and the FLACA was 9 out of 10. Acute necrotizing fasciitis due to NK cell deficiency. A child report was referred to us for excess crying, and NRS was 7 out of 10. Burn, which is so common, which we see because it's a tertiary hospital, we get a lot of referral related to burn. One case a child brought with accidental hot burn, scald, and numerical rating was 7 out of 10. Another child with accidental burn injury, 40% burn, FLACA 9 out of 10. Another example, arthrogryposis, 5-year-old baby, excess crying because of with the handling, cries inconsolable, NIPS is 4 out of 7. Osteogenesis imperfecta, referred to us for pain and excess crying while handling and feeding. NIPS was 5 out of 10. So these are just letting you know different painful condition. Again, very unusual. This may not be there in textbook, but we see a lot like a congenital hydrocephalus with ruptured meningomyelocele. Often they are referred, by the time they come to a tertiary hospital, it's already ruptured, and it can be extremely painful in this situation. And various hematological conditions which are very endemic to our region, like sickle cell, hemophilia, and von Willebrand disease. They come with various crises, and they score very high degree pain in this situation. And of course, the number of painful procedures they go for as a part of diagnostic and treatment in NICU, in pediatric ICU, and in general pediatrics. In cancer, like I already mentioned, undergo tremendous amount of suffering because of painful procedures. So, what is the impact of a child experiencing chronic pain? There's so much of now evidence indicating that exposure to pain early in life has a very long lasting consequences, which may be in terms of increase in the risk of developing problems in adulthood like chronic pain behavior, anxiety, depressive disorders, post-traumatic stress disorders, and various other immediate as well as long-term consequences. So, like I said, it's so common to see pain in this our population, and there are some unique situations which we see very prevalent to our population. Its number is huge, a large number of children experiencing pain and wide geographical distribution. They all eventually go back home in the very remote rural setting, very limited to health care, and they suffer in pain. So this challenge of providing quality versus coverage, this always is a challenge. Another unique situation is the unique need of our children is high symptom burden and enormous need for prevention relief of suffering. Because of these painful conditions which we see are very different from how textbook describes. And many are preventable. That is the sad part of it. If they have access to good pain support team, these painful conditions are quite treatable and preventable as well. And broad heterogeneous conditions requiring pediatric palliative care and pain relief. Like it's beyond, again, it's like infectious conditions and malnutrition, like I described as an example. These are all very broad and painful, the pain conditions which we see very broad and heterogeneous. And how do we cater to all of this uh, population without being excluded? And unfortunately, like I said, most are left untreated. They suffer and often they die in pain. Very interesting. This, the cultural and the social context in terms of pain assessment and treatment. I won't say barrier. We have to be culturally competent to understand how they perceive pain in terms of culture and the society in general, and they respond to treatment. Remember that in most of our population, parents and extended family very much participate in a child's care plan in terms of if their child has a disease, communication and decision making. And they may influence how the child is being reported or treated. There's a deep-rooted belief system related to suffering, death, and dying, which heavily influences how they perceive pain, how they report pain, and how they accept treatment which we give to pain. So if we are dealing as a pain program and as a pain team, when we're dealing with our children, we have to be really culturally sensitive and competent to help them with their pain conditions. And like I said already, stigma around pain expression and seeking medical care.
Good morning, good afternoon, and good evening, and welcome back to our annual Pain Center Conference, Advancing Pediatric Pain Care Equity, Addressing Challenges and Opportunities in Low and Middle Income Countries. For those I haven't had the pleasure of meeting, my name is Fiona Campbell. I'm co-director of the Pain Center at SickKids, and I'll be your moderator for this session entitled Chronic Pain in Children in India, sharing insights on the unique experiences of providing care in the hospital and in the community. So it is my distinct pleasure to introduce Dr. Gayatri Palat, Professor of Pain and Palliative Medicine at the M&J Institute of Oncology and Regional Cancer Center in Hyderabad, where she was instrumental in founding the department. She has about 23 years of experience in pediatric palliative care, and in addition to being a founding member of the Pain Relief and Palliative Care Society, one of the largest palliative care programs in Telangana. Dr. Palat leads a unique pediatric palliative care program embedded within tertiary government hospitals and extends into the community through home-based care and hospice support for children. She also directs a highly successful fellowship program in PEDS palliative care endorsed by the Royal College of Pediatrics and Child Health. Her efforts have also been instrumental in developing district-level palliative care programs across her region. Dr. Palat serves on the Board of Trustees of the International Children's Palliative Care Network. And with that, I will introduce Dr. Palat.
Often this is given a very low priority, and which reflects in not having age-appropriate pain assessment tools, medications, equipment tailored for these required for these children. Access to opioid medication, huge inequalities. Most of you must be aware that six developed countries account for in adult, six developed countries account for 79% of the global consumption of morphine. And if you look at some painful conditions in children, the pain is so profound, your paracetamol or any weak opioids may not be enough to manage those pain conditions. You need strong opioids. But the sad situation is that in many developing countries, which make for 80% of the world's population, account for 6% of opioid medications are being available. So 2/3 of the world's population are left with no access to opioid for pain relief. That is the reality today. And like I said, the real paucity of data. Most research are done in developed country. So we don't have a robust data on pain prevalence and impact, especially in pediatric population, making it difficult to design a targeted intervention. So, what are the opportunities which we can make use of in order to overcome all of these challenges? Age appropriate tool. It's very important we think about developing, and not just development but also implementation of existing, which are already developed in many population, implementation of pain assessment tools which are suitable for different pediatric age group. The standard adult tools may not be valid or reliable for children. Interventions must be adapted to children's developmental stages, communication abilities, and cultural contexts. We have to engage the family. Engaging families in pain management process improves outcomes. Several studies have substantiated that. Education and support for caregivers are essential, as health literacy is very low among this population. Engaging community health workers and local leaders can play a vital role in raising awareness, reducing stigma, and supporting families. We need to constantly advocate for child-specific policies that prioritize pediatric pain management, including funding for research, training, and resources. Research priorities. More research is required to understand the epidemiology of pediatric pain in low and middle income countries and to develop evidence-based guidelines, which is more for the guidelines suitable for the low and middle income countries. We need to invest in training programs for healthcare providers. All healthcare providers dealing with children, a child health, should be trained in basics of pediatric pain so that they recognize pain, they make an effort to prevent pain, and if required, do the basic pain management. We should utilize the multidisciplinary presence and encourage collaboration to ensure holistic care for children. Partnership. Always partnership help in enhancing pediatric pain and palliative care support. So we can make use of the global as well as regional partnership and collaboration. What it brings is what is the best practices existing in other places. When we have lack of resources, sometimes this collaboration helps us to fill that gap, bring resources, and support local initiatives. Some very successful examples are there globally, which are very relevant to low and middle income countries. Like many community-based programs have shown that when you engage community, it helps to improve pain management by leveraging local resources and knowledge. Similarly, some successful programs have utilized telemedicine and e-learning platforms to train providers and support families in remote areas. The program which I do in Hyderabad, like I said, we have two programs in Tertiary Cancer Hospital and Tertiary Children's Hospital. But again, because both are public hospitals, we have very limited resources. But opportunities which we used is a presence of very strong local non-governmental organizations which is there in Hyderabad. We collaborated with them and we developed a very robust program which is there in the hospital as well as in the community. So in the hospital, when we developed this program, we over a period of time we managed to have a hospital policy on pediatric palliative care, which really helped us to integrate. The program became embedded in the hospital oncology as well as non-oncology setup, and that led to early integration, prevention, and relief of suffering. We have this policy of zero tolerance to pain in children with cancer in MNJ Cancer Hospital, which means that our nurses go around the ward. They screen every child for pain, and when the pain is being reported as moderate to high, immediately it is escalated to treat pain. Similarly, we have a very good procedural pain protocol established in the hospital. Our hospital has uninterrupted supply of all opioid medications so that the child gets the privilege of getting all opioids as and when they require. Like I said, the child goes back to the community. We take help of the NGO. NGO is called Pain Relief and Palliative Care Society, which runs a very beautiful home-based palliative care program as well as hospice program. So we connect with them, and the child gets the continuum of care wherever they are and whenever they need it. In terms of capacity building, we have many training programs happening in our center in Hyderabad. So it is actually evolved to become one of the nodal center for pediatric palliative care and pain management training and capacity building. We get fellows, we get students from many Southeast Asian countries coming for their training, the nurses, the doctors, and many specialist pediatricians. And one of the very successful program is Fellowship in Pediatric Palliative Care, which is now recognized by RCPCH for its rigorous quality and standards and the success and the impact which has made in the Southeast Asian region. Some other courses, short courses which we do is ECHO courses in pediatric palliative care and certificate courses. We have collaborated with Indian Academy of Pediatrics, and through that, which is a national association, and through that we provide basic and advanced courses for many pediatricians practicing pediatric pain. So to conclude, advancing pain care equity in low and middle income country settings require a multifaceted approach. By prioritizing education, capacity building, policy reform, and community engagement, we can bridge disparities and ensure that effective pain management becomes a universal standard rather than a privilege for every child in pain. Thank you.
I mean, that was really an absolutely terrific presentation. It's really amazing the work and the standard that they are holding to account for pain management and palliative care in Hyderabad. I'm hope if any of you have questions, please send them back. Please send them to our Pain Center email address, which I just put in the chat, and we will make sure that she receives them. Between her presentation and other presentations over the course of the 2 days, we really have got a snapshot of some terrific things going on in India.